Yes.
Very well. And Augusta, can you guys hear me as well?
Yes, ma'am.
Awesome. So I'm happy to be here with you all. For those of you who don't know me, again, my name is Dr. Osai. I am one of the M-Care practitioners here in Southwest Georgia. Today we are going to be beginning with transitions of care. I'm hoping that this is way more interactive than it was last year. I'm hoping that we took the comments that you guys or your predecessors gave us and made it a little bit more interesting. I'm also hoping that you guys are able to take a look at the pre-lectures that I had posted, because it's really going to give you the foundation you need to be able to work on this case together in your groups. So, things of note that I want to tell you guys before we get started: we are going to be answering questions as a part of our groups that you have, so I will be calling on them at random. I literally just took a random number generator, ran it in Excel, and so I'll be calling the numbers in that order. So everyone should be prepared to answer those questions for this case. I'm hoping you guys find this as interesting as I do, so let's go ahead and get started. One of the first things that I want to bring to your attention, I'm sure you guys feel like I might be beating a dead horse here, but is the patient care process. You have seen it in your curriculum before, and normally where you focus your time is with those 5: collect, assess, plan, implement, and follow up. But where I want to bring your attention, and where you may have talked about the patient care process previously as well, is in that inner circle, where we're going to collaborate, communicate, document, and ultimately achieve this patient-centered care that we're working towards. So when we look at this patient care process, it all works together. But in these next 2 weeks, we're really going to spend some time focusing on how we impact that inner circle, and not so much on the outside 5 that we usually talk about. Okay? So, you guys have these slides. I recommend that you work off of the doc that you guys have, the Word document, in terms of the cases for you to move forward, because there's a little bit more information on those pieces of paper in terms of vitals and so on. But we're going to meet Jo. We're going to find Jo in the emergency department or the emergency room. 62-year-old Asian female who presents to the ED with complaints of chest pain. And upon exam and further diagnostic tests, she's diagnosed with a STEMI. So group 21, if you are in group 21, can you let me know in layman's terms, what is a STEMI? Layman's terms.
In layman's terms, a heart attack.
Very well. So our patient Jo has had a heart attack. Perfectly, that's what I needed to know. So we have a patient with a heart attack in the ED. We're going to follow her through her hospital stay as well as her follow-up. So in terms of our past medical history that we know about this patient, this is the type of patient who doesn't go to the doctor, doesn't really know what's going on with their health. They're really unaware if they have any past medical history issues. Social history, we have that she smokes 2 packs per day and drinks 2 to 4 drinks per evening. No known drug allergies. And the only thing that she can tell you she's taking at home is OTC omeprazole daily for some heartburn. Okay? So I want you guys to take the next 10 minutes in your groups and think through, based off of what you've learned in your pharmacy curriculum about transitions of care, based off of what you've learned about clinical care of patients in the ED, what types of things do you need to do as a pharmacist who would be finding this patient in the emergency room? What types of things do you need to look at, be interested in when it comes to this patient? So take some time, take 10 minutes with your groups, think through what needs to be considered in the emergency department regarding transitions of care, and we're going to come together and talk about it as a group.
What are they talking about? From the ED to home, maybe?
Maybe.
That's what I figured. Guess, yeah, call and see which medication she's on besides the results. Yeah.
heartburn, oftentimes this is if you have a heart attack in females. So maybe she was just taking it because she thought she had heartburn. She didn't have a heart attack. The invite to your Gmail. Let me know if you don't. Kendall, did you make one too?
Yeah, that's the same one.
I did. But we'll use whatever.
This semester we should equal to instead of having
I
to
like
scroll
that.
through one.
I'm very for that.
Maybe we could just like,
Here, I can make a folder.
yeah.
Yeah,
Just keep everything in there because
yeah, I would kind of like.
trying to study for finals was an epic nightmare.
I was trying to like do some of that stuff, and this would not work. A waste of time. Alright, which one?
Kendall, I think you're gonna have to move it.
Okay.
Because I don't own it.
Let me check my email.
Do it.
I said, let me check my email and I'll.
I'm just rolling.
Did you like invite us to the folder?
I just sent the link.
Yeah, I'm saying like, my 2 agents.
I haven't gotten it.
I texted it.
Oh, you texted it. Okay. staying in the hospital one more day? ELD? Or will we just start them on oral day?
Which one are you on?
I'm just working on the next one. Right, what's even so I remember insulin, like, if they're at 10, she would initiate insulin. But, I mean, she's inpatient, so you'd obviously do it inpatient. If she's going 10, yeah, that's weird.
I think 10 is when you initiate insulin outpatient. Like that's when like you schedule and then you start on that without trying hormones first. I think she would probably just be discharged on.
Discharge her on like.
She was just discharged on oral meds because it's still like under that 180 range for the hospital rate.
But
All right, guys, let's reconvene. Give you guys about 10 minutes to take a look at what would be done in the ER. I had a request to go back to the patient care process and kind of explain this just a little bit more slowly. I apologize. I had thought that you guys had gotten this a lot, so I'll take a little bit of time here. So you guys are familiar with the collect, assess, plan, and implement portion, as well as follow-up. And what I'm hearing is that most of you may not have even known there was a middle to this circle. And so where we're going to focus our time in transitions of care and where I want to bring your attention over these next 2 weeks is that middle. So as you can see, there's a blue ring that says collaborate, communicate, and document. And then in the very middle of the circle are the words patient-centered care. And the reason that this is important is because this is where the entire healthcare realm is really trying to move to, is this patient-centered care thought process. So how do we make the care that we're delivering, whether it's the medications that we're giving, the diagnostic tests that we're recommending, how do we make it so that what we're delivering to the patient is what they are interested in? How do we involve them? How do we make sure that they're appropriately educated and involved in the process so that they have a say in their healthcare too? And so where I want to focus our time over these next 2 weeks again is on the blue ring and the white circle in terms of patient-centered care, how we collaborate, communicate, and document. And all of those things help us collect, assess, plan, implement, and follow up to a higher degree. So this entire image really works together, but we're going to take some time and tease out how we do the blue ring and make it all patient-centered care focused. So you've had a little bit of time to look at the emergency department, see what was going on there. Group 19, what kinds of things did you come up with in terms of what we need to think about when it comes to transitions of care for this woman who's just had this heart attack diagnosed in the ED?
Contacting the family and making sure that she doesn't have any other medical history or medications that she's on. Potentially calling pharmacy to see if she's on any medications, just to make sure. Because on this case it says none. And then get like a statement from family about what's occurring or what's happening to her.
Very good. So, group 22, is there anything that you had extra, anything different from what group 19 has just stated?
Yeah, a little bit. We should consider the patient's insurance plan, just to keep in mind of if you want to refer them to an outpatient to a pharmacy place to know what may or may not be covered. We want to consider if it's the appropriate time for transition of care. You don't want to take them out of the ED too soon, just have them go back in later. Also want to consider getting confirmation from their primary care provider about any medical conditions they might have. And also continue to monitor their blood pressure, heart rate, and those other vital signs.
So I'm going to ask for clarification. You stated appropriate time for transitions of care. What did you mean by that? Or what did your group mean by whether or not it's the appropriate time?
I guess just making sure that what they're admitted for has been treated well enough so that if they get switched over to a different facility, their symptoms won't get worsened or they won't regress and go back to the emergency department.
Okay, very well. So thank you guys for sharing what you found. what I'm going to do is go through some of the things. Everything that I've heard is reasonable. I will add to the appropriate time for transitions of care. Here I want to plug, transitions of care is not just about leaving the hospital or going to another facility. Transitions of care is involved in going to different floors in the hospital. So it's considered transitions of care when you leave the ED and go to the cath lab, or when you leave the ED and go to the cardiac floor, or when you get discharged from the hospital. So at any point that a patient is moving to another unit or to another area in a hospital or to another possibly entirely different clinic. So even going from home and coming into the emergency department is a transitions of care point where we can have some impact, okay? So it doesn't just mean leaving the hospital when you say transitions of care. It's at any point when a patient is moving from one place to another, how can we impact that patient's care? So a lot of the things that you guys said, definitely on the money for transitions of care. Some of the things that I want to share with you. I heard verifying medications with a pharmacy if the patient has one, that's perfect. All in all, that thought process and the word for that, I'm sure you guys have heard it, is medication reconciliation. So whether you're doing that with the pharmacy, whether you're doing that with their family members or their caregiver, or whether you're having that conversation with the patient. Now, someone who's having a heart attack may not really have the faculties to talk about their medications with you, but you can contact caregivers, as it was stated by one of the groups, or contact the pharmacy. And so a full med rec, what you're looking at is not only prescription medications that the patient is on them, but it's also going to be any herbals, supplements, over the counters. And so as we saw on the case, this patient did have the faculties to tell you, I'm taking some omeprazole over the counter. And so for her, because she doesn't really have a lot of experience with the medical field, she doesn't really go to doctors, that's really the only medication that you have. But here, in terms of our inner circle of our patient care process, it's really going to be important that for your entire healthcare team and for the providers that are in the hospital, that you're documenting that that's the only medication that she's on. They need to know that this is the only thing that they're combating, or this is the only thing that they would need to start at the hospital in terms of continuing her care from home, okay? Some other discussions that you can have with the healthcare team. We know in her social history that she both drinks as well as smokes, and so what are you going to do with that? When she gets on the floor, now that she's in the hospital, you can't particularly light a cigarette when you're in the cardiac unit. So do we give her any therapy for that? Do we have to think about a protocol in terms of her drinking and her smoking that we can make sure that she's comfortable in-house, okay? I heard from the group collaborating with the family, I also wanted to say that here, getting in touch with her family to find out if there's any family history that's going to be something that we need to think about is going to be important. So that was a really great catch there. At this point, and at any point when you're discussing with patients, you can even provide some patient information. So you guys know what heart attacks are, you know the pathophysiology of them, you've gone through pharmacotherapy, and so being able to share that with the patient is going to be important. Some people may say at the point where they're in the ED and suffering from these symptoms is not the best time to provide a lot of education, but you can give a few small tidbits, because you must imagine a heart attack is going to be scary. And so for a patient who doesn't really understand what's going on, being able to share with them in layman's terms what might be going on with their body and what's going to happen from here on out could be very comforting for them, and comforting in their transitions through the hospital as they proceed. The most important part here in terms of being in the ED, and the most important part when it really comes to taking care of patients, is a clear communication to all parties involved. So that's going to be clear communication, whether it be to your healthcare team, to the other pharmacists that you work with, to the patient's family, to the patient themselves. And so ensuring that that clear communication is present will allow you to complete that patient care process in an appropriate manner, okay? So those are some of the things that we can take a look at, in addition to the things that you guys mentioned when it comes to transitions of care. To speak to some of the points that you guys said specifically, I've heard taking a look at insurances. It may be a little bit early to take a look at those, because what I'm assuming is you meant pharmacy insurance, or like medication insurance versus medical insurance. So we may want to wait until discharge to really key in on what that insurance looks like in terms of the therapies that they can be getting when they're getting discharged. And we'll come to that when we get to that point. But all of the other things that were mentioned were appropriate things for transitions of care, okay? So now that you guys have a better idea, a better understanding of what we mean by transitions of care, let's move on to our next point with our patient. So we have now landed on the cardiac floor. She received 2 stents after being diagnosed with her heart attack. This is her second day on the cardiac floor. And there are discussions with the team. You've been reading the patient notes, and she's going to be here for one more day. She has dispo as of the day after tomorrow. Her lab revealed a fasting blood glucose of greater than 126. So, and an A1C of 9. So group 12, can you tell me what that means? What are we worried about now?
We're worried about diabetes in this patient.
Very nice job. So, we did fasting labs. Everyone gets fasting labs in the hospital if they've had a heart attack. We get them every morning. And those fasting labs told us we had a blood glucose of greater than 126. And so protocols in hospitals typically say when you have that, you should run an A1C. Now we know that this patient is going to be diagnosed with diabetes. Makes sense that she probably didn't know that before because she doesn't really follow up with healthcare. And so this is what we have in front of us. We're on the cardiac floor. We have a new diagnosis of diabetes. You guys see the inpatient medications that she's taking currently there. You have vitals as well as labs available for you on your Word documents. My question to you all for the next 8 minutes, take some time. Now that we have a stronger understanding of what we mean by transitions of care, what types of things as a pharmacist should you be thinking through? Taking a look, I want you guys to look at the medications. Think about her new diagnosis. What kind of conversations do you need to have, whether it be with the patient, the healthcare team? How can you optimize the therapy she's on? What are we looking at for transitions of care solutions? Take some time with your groups, about 8 minutes, and we'll come back together.
We're on the second one now. Next question.
We're on the second one.
I don't think you initiate. Would you initiate insulin? That's what we were talking about. Well, she's only going to be there for another day.
Or she's only going to be there for another day.
I mean, if she was like, 400,
Yeah.
then you would definitely do it. But,
Get that down a little bit.
but it's like, yeah, metformin, like, what, 500 twice a day would be like starting. Okay, Ben. We have them. We just tell people that.
Well, we don't have any. Sorry.
But why did you choose it? Publix doesn't do that, you know, like gift cards anymore.
No, yeah, those stopped on the 31st.
They also stopped doing some of the free medication.
Tell them to try like a CVS or
Seems like
something.
a bunch of pissed off people.
We haven't had anyone pissed off yet.
Huh?
They're not podcast. We don't blame them anyway. I know Walmart, is Walmart still doing it? Because they call us and they're like, hey, what's your price on this? And like, it's free. Okay.
Do you know, it's because not my money, Kroger got their own health insurance. Like you pay $30
It's $37. Yeah, I saw that. I was looking at prices and I'm not good already.
Yeah, it's a lot of medications, but it stinks because a lot of our patients. There's two A. We're not thinking about a lot of our patients are on combination drugs, and so in order to get the discount, they have to separate the drugs.
That's where it works.
It's probably cheaper than support. It's worth it.
Yeah, I mean, if you're going to pay like $100 for like Janumet or something, just
Yeah.
keep it for it.
But it does have a lot of drugs on it.
It's really good for people who are
There's even testosterone. There was a testosterone. Yeah, and I was like, what?
You're going to put controls on this. We have $2 Xanax. $6 Northfield.
Oh, Aaron, I just saw this thing on Instagram and it made me think of you. I read that and Aaron.
So now what? I was actually pretty surprised that no one was like, what?
I'm surprised that I haven't gotten anything to be like, I'm sorry, singular is not free. I told them, like, when people go to transfer, I'm like, I just want to let you know, like, it's on a free listing rate. And they're like, oh, that's right. I was like, it's $11.95. They took that one, and it's spironolactone and trazodone. Those, but yeah, I always tell them, like, it's $11.95 cash for the 90 days supply.
I had a guy get really mad at me on the 7th because he came from a dermatology clinic with a thing on his nose, like he just got something removed and they wrote for like Norco or whatever, but the doctor put 118. I was like, oh my god. I typed it in, I was like, honestly, I hope my pharmacist wouldn't touch it. So I put it in, she brought it back to me, she's like, Aaron, it says the 18. And I had to explain to him that we cannot fill it and we can't change it over the phone. It says the 18. He's like, give me a pen, I'll do it. I was like, no.
Give me a pen, yes, you can do that.
Yeah, but then I was like, just come back in 20 minutes.
Yeah.
And change it and then fill it. And I'll fill it for you. Yeah.
Okay.
I mean, I was like, I'm not going to make you drive 45 minutes back and back here.
Pretend like you went to your doctor. Change it in your
I
car.
sometimes like leave and come back in 20 minutes with a different date on it, and I won't tell anyone.
I didn't see it.
Not my license on the line yet, so
I'm just an intern. Don't pay me enough to get.
they're not allowed to do that.
Oops, just like that.
They have a lot of like, stupid things like that, and I'm like, maybe my pharmacist wanted this. I'm not gonna tell them. Just because I think it's okay, and it's not gonna be my fault if I feel it.
Exactly. Everything else on that. Don't worry about it. Yeah.
What's for you know?
Aiken.
She's in the Asian store. Is that a drive?
So
That's like huge store, right? Aiken, like, really busy.
Yeah, it's really good.
It would be a drive for like where you
That's 15 minutes when I get there.
They just said something about a donut hole, so I was like, well, they know what they're talking about. So when I went out there to do our grass measure, it was like, ready to go up. But I got
Hearing him talking about retail pharmacy, I'm just like, I don't have to touch insurance anymore.
Yeah, I don't know. I feel like I like literally can put the insurance in and it tells me to reject it. So what I do, I can fix it. But it's not like, nope,
If it's like a whole bunch of like random words, I'm like, I'm just gonna leave this here and someone else can fix it.
leave that.
I can like fix everything. I just let the pharmacist do the DUR codes, unless it's like something.
Yeah, someone literally just showed me how to do those.
Really? My pharmacist always tells me, I was like, I'm an intern. I confidently like talk to the patient about this stuff. But it says pharmacist do this.
Oh yeah, Josh tried to be like, can you override that? No. He's like, try. Let me see what
Like, they
happens.
don't even give me an override code for something over $10 on the register. Why can I override something that's one's medication?
Yeah, no, I don't want to be honest with you, but I don't want Josh to know I did that because then everything will be like, Jenny, go clean in your No, I'm not doing that.
Do you work with Amber? Do you work with Amber?
I work with Amber, yeah.
Yeah. I work for Publix. So she's been filling in at our store.
525?
Yeah, I heard that Josh and Amber don't get along or something.
Lots of people don't get along.
I don't like Josh.
I've
It's
heard.
because he doesn't like help out.
He's slow as fuck.
But he's a pharmacist, right?
It's because like nothing gets done when he's there, and everyone gets
No pause or nothing.